Blumenthal is running a few minutes late, but on his way, and I assume that we'll have a number of our colleagues join us. We have a vote at 4:30, so we'll have to figure out that circumstance as well. I appreciate our witnesses joining us today and for the important work that you all do to support our veterans and their families. As we know, our nation owes veterans the assurance of receiving safe, high-quality, and effective care through the Department of Veterans Affairs. This includes making certain that the medications that are being prescribed are designed to support their recovery from trauma, pain, and mental health challenges and are being paired correctly with the right support system. This responsibility is central to this committee's mission, and it is the focus of today's discussion. Recent reporting by the Wall Street Journal has raised concerns about the use of multiple central nervous system medications among veterans, often referred to as combat cocktail. These stories raise the question of how widespread these practices are, their origins, how the VA is addressing this issue, and what VA's oversight and accountability mechanisms are in these instances. Medication is critical to the overall care and well-being of many veterans, and nothing from today's hearing should suggest that veterans should hesitate to seek treatment or that evidence-based medications are unsafe or unwelcome in any way. Over the past decade, the VA has made significant progress in reducing opioid prescriptions through promoting safer options, expanding programs that support holistic health, and implementing new oversight measures to identify high-risk medication combinations. This hearing, however, provides an opportunity to assess progress, discuss effective strategies, and identify gaps that still remain. Veterans deserve the trust in the system, and that's exactly why we're here today. This includes understanding how the VA trains clinicians, monitors prescribing practices, and implements policy to make certain veterans have access to non-medication options like therapy, pain management, and community programs, along with discussing whether private sector models or technologies can offer insights and ultimately help the VA to better serve veterans. Today, we'll hear from VA officials who oversee prescribing practices and mental health policies across the system. The goal is simple: simply want to understand the scope of this issue and determine what steps the VA and Congress can take to guarantee that veterans receive safe, effective, and personalized care. The men and women who have served our nation deserve nothing less. As I indicated, Senator Blumenthal is expected to join us shortly, and we are going to proceed with the first panel. Testifying on this first panel today. What are you telling me?
This is the panel that's testifying.
Oh. Testifying on the first panel, which is on my sheet, the second panel, is Dr. Julie Kroviak, Principal Deputy Assistant Inspector General for the Healthcare Inspections, U.S. Department of Veterans Affairs, Alyssa Hundrup, Director, Healthcare, U.S. Government Accountability Office, and Erin Fletcher, Wounded Warrior Project. I appreciate you witnesses willing to testify, and we'll begin. Ms. Hundrup.
Chairman Moran, Ranking Member Blumenthal, and members of the committee, thank you for the opportunity to discuss our work related to medication management at VA. My testimony today covers various related GAO report findings and recommendations. Effective medication management is essential to ensure veterans receive safe and comprehensive treatment. This is particularly important for veterans experiencing mental health conditions, which have been a persistent and growing issue. Many veterans also live with chronic pain, often because of injuries from their military service. Veterans may receive medications such as antidepressants or mood stabilizers, as well as opioids for pain management. Some veterans have multiple chronic and mental health conditions, which may necessitate the use of numerous medications, increasing the risk of polypharmacy. If managed improperly, polypharmacy can lead to adverse health outcomes or even overdose or death. As such, it is critical that VA ensure it is offering effective treatment, including medication, as well as non-pharmacological options such as therapy, to reduce the risk of negative outcomes. In 2019, we examined VA providers' treatment plan decisions for veterans with mental health conditions. We found veterans received a range of treatments, including talk therapy, one or more psychiatric medications, such as anti-anxiety or antidepressants, or a combination of the two. At that time, VA did not have guidance on or monitor providers' documentation of required treatment options in the plans, so we made 2 recommendations to address these issues. Since then, VA agreed with and took action to implement the recommendations. Specifically, VA providers are now required to record mental health treatment plans as separate, easily identifiable documents in medical records. The plans are to clearly show what treatment is being provided, the different treatments that were considered, and whether any changes may need to be further considered going forward. VA also developed an approach for monitoring the consideration of different evidence-based treatments, including both the prescribing of medications and therapy options. With this approach, VA is in a better position to ensure providers are considering all available options and providing the most appropriate treatment to each veterans. Importantly, with this information, VA is also in a position to evaluate the prevalence and appropriateness of polypharmacy and minimize the risks that it can bring, including overdose or death. Additionally, we've examined issues related to VA's implementation of its opioid safety initiative. At the time of our report, VA had reduced opioid prescribing rates, but we found VA did not consistently follow some risk mitigation strategies, such as conducting annual urine drug screening or requiring informed consent for long-term prescribing. We made recommendations to address these issues, and VA has implemented them. For example, VA created a planning tool for primary care providers related to reviewing and documenting each of the risk mitigation strategies in veterans' medical records. With this tool, VA can better ensure providers are following the strategies. In light of the very serious risks that opioids pose, including addiction and overdose, it is critical that VA ensure it is maintaining careful oversight of prescribing so that it is done in a safe and effective manner. Lastly, the availability of mental health services is especially important for service members transitioning out of the military, as this is a particularly vulnerable time. The transition period can bring stressors related to housing, employment, and family reintegration, and these veterans are susceptible to mental health conditions. In our 2024 report examining mental health services for transitioning service members, we found VA and DoD identified a number of helpful touchpoints, such as pre-separation counseling, but the 2 departments have not assessed the effectiveness of their collective efforts, and we recommended they do so. VA has also agreed with this recommendation and stated that it will coordinate to establish a plan of action to implement it, including identifying any gaps in services or duplicative efforts. It is important for VA to take action to address our recommendation, and we will carefully monitor the steps that VA takes going forward. Addressing our recommendation will help to ensure the departments are most effectively offering mental health services to veterans as they readjust to civilian life. This concludes my prepared statement. I'd be happy to answer any questions that you may have. Thank you.
Dr. Kroviak, welcome and thank you for your testimony.
Chairman Moran, members of the committee, I am pleased to testify about the oversight conducted by the Office of Inspector General regarding VA's medication management practices. A fundamental healthcare activity is a medication reconciliation process involving providers, patients, and their caregivers that ensures they are aware of all medications a patient is prescribed and taking, including over-the-counter and supplements. Medication reconciliation, required by VA, can be time and labor-intensive, but it helps verify that patients are taking their medications as prescribed and that each medication's risk and potential side effects are understood. It can also reveal or prevent duplicative treatments, contraindications due to allergies, and potentially dangerous drug interactions. Medication reconciliation is most critical during care transitions, such as when a patient is discharged from a hospital, moves between different levels of care, or receives VA and community care. For those patients with chronic or difficult to treat conditions, including mental health conditions, the risk of polypharmacy, being prescribed multiple medications, is real, but it does not always mean a patient is receiving poor care. Veterans are at higher risk for psychotropic polypharmacy, that is, being prescribed more than 2 medications that affect mind, mood, and behavior. This can occur because of their distinct military experiences that lead to complex and treatment-resistant mental health diagnoses. The OIG has noted deficiencies in medication management in several of our reports on VA healthcare. We uncovered noncompliance with required processes for patients being discharged from acute mental health care settings. For example, only 37% of electronic health records at the Philadelphia VA included clear discharge medication instructions, which are essential to prevent medication errors post-hospitalization and ensuring continued recovery. Patients must also be educated on potential risks associated with their prescriptions. Many antidepressants, for instance, carry black box warnings due to their increased risk of suicidal thoughts, particularly in young adults. One tragic case reviewed by the OIG revealed serious deficiencies when a young veteran, who ultimately died by suicide, was prescribed an antidepressant without being educated on the risks and was not provided timely follow-up care to evaluate responses to this new medication. This case highlights the critical value of patient education and timely follow-up care. In addition to challenges with safe prescribing within VA, the OIG is concerned with safe prescribing for veterans receiving community care. A significant troubling area remains the oversight of opioid prescriptions written by community care providers. VA is required to ensure community providers review and acknowledge VA's Opioid Safety Initiative guidelines. However, we found inadequate oversight of VA's third-party administrator's certification that community providers reviewed these guidelines. When community providers are not even aware of VA's expectations for safe opioid prescribing, VA cannot guarantee the safety of those veterans referred to the community for chronic and acute pain management. Our review of the VA Eastern Kansas healthcare system highlighted further inadequacies in coordination and oversight of medication management involving community providers. Among other issues related to patient safety for veterans referred to the community, we found incomplete documentation verifying safe opioid prescribing practices and a lack of documented medication reconciliation by community providers. In conclusion, VA's dedicated clinical staff work tirelessly to provide high-quality care tailored to each veteran's needs. Such care can involve multiple treatment modalities and medications. Patients and caregivers must be empowered to manage their care with accurate medication instructions, an understanding of treatment expectations, and knowledge of potential side effects for each medication. The OIG is committed to independent oversight. Our teams of dedicated medical professionals are uniquely positioned to assess and drive meaningful improvements in the quality of care delivered by both VA and community providers. Chairman Moran, Ranking Member Blumenthal, and committee members, I'm happy to take any questions you may have.
Thank you, Doctor. Erin, Fletcher, welcome again. Your testimony will be received.
Thank you. Chairman Moran, Ranking Member Blumenthal, and distinguished committee members, thank you for today's hearing and for the honor to join you on behalf of Wounded Warrior Project and the warriors and families we serve. Our vision to foster the most successful, well-adjusted generation of wounded service members in our nation's history brings with it the responsibility to identify, address, and serve the mental health needs of veterans who reach out for help. In our most recent Warrior survey, 77% of warriors reported PTSD, and more than half presented with moderate to severe PTSD symptoms at the time of the survey. Nearly 2 in 3 reported one or more mental health conditions, and for many of the warriors we support, mental health challenges can be worsened further by poor sleep, chronic pain, and feelings of isolation. Recent reporting about polypharmacy has highlighted how overmedication can be one of the many challenges veterans face on their road to recovery. Poor access to therapy, canceled appointments, and stigma can also frustrate even those who are most motivated to find care. But there is reason for hope, and we can frame strategies for improvement around stopping overmedication, increasing access to care, and embracing innovation. Regarding overmedication, recent research has shown that 28% of post-9/11 veterans receiving VA mental health care met criteria for central nervous system polypharmacy. One way to help reverse these trends will be for Congress and VA to continue their investment in precision medicine. By moving beyond one-size-fits-all care, precision medicine enables more accurate decisions that improve outcomes and reduce unnecessary or ineffective treatments. Congress helped launch VA's initiative for precision mental health to identify and validate brain and mental health biomarkers and translate those findings into improved clinical care for veterans. With consistent support and funding, as well as expansion to consider low-level blast injuries, this initiative can transform the way medication can supplement evidence-based therapy. Increasing access to care will help move away from what some veterans observe to be a medication-first approach at VA, in which prescriptions are offered before therapy or without consistent access to evidence-based treatments. But as our country is struggling with training enough providers to meet increasing demand for mental health care, we can broaden our perspective on access. Veterans increasingly express interest in non-pharmacological and complementary therapies to supplement their clinical treatment. Mindfulness, yoga, acupuncture, Tai Chi, and other integrative approaches provide coping skills, stress reduction, and support between therapy sessions. Congress and VA can help extend more access to approaches like these by renewing commitment to VA's whole health program. Even with over 100 whole health locations, availability still widely varies across VA facilities. Without a consistent, centralized implementation model, many veterans remain unaware of available resources or encounter barriers in accessing them. Moreover, capacity constraints in frontline clinical treatment make access to these services even harder to obtain. These barriers can leave veterans relying solely on pharmacological interventions. Lastly, innovation can help set new strategies to ensure veterans have access to evidence-based treatment. Forward-thinking approaches to case management are one area where we can drive change. We've found success with offering veterans regular touch points to reduce frustration, ease confusion, and help them stay engaged while they navigate the clinical system. In a VA context, one example that we have found extremely effective is the post-9/11 Military to VA Case Management Program. This public-private partnership model allows VAs to place liaisons at certain partnership sites as veterans complete specialized treatment within the community. For example, VA liaisons are on site at our Warrior Care Network academic medical centers, where veterans receive intensive outpatient care. The VA liaisons help veterans obtain VA medical records, schedule follow-up appointments at VA after discharge, and serve as a direct point of contact should the veteran have questions about their VA care in the future. At these sites, 90% of participating veterans return to VA for ongoing care, which is evidence that structured, proactive, and collaborative transition support helps prevent veterans from falling through the cracks and help maintain gains achieved in treatment. In conclusion, I'd like to recognize that VA is our biggest and most important partner in helping veterans access the care and support they need. It is critical that we give VA the tools it needs to succeed, and with Congress's help, VA has made progress in recent years to reduce overprescriptions, improve oversight, embrace innovation, and strengthen its mental health care system. We are hopeful that the challenges being discussed today will be the focus of even more effort to ensure that veterans receive the best possible support when seeking mental health care. Thank you for this invitation to testify, and I welcome your questions.
Thank you very much. Before we go to questions, let me turn to the Ranking Member, Senator Blumenthal, for his opening statement.
Thank you. Thank you, Mr. Chairman, and my apologies for my lateness. I'm going to put my statement in the record, but let me just thank you and thank the witnesses for being here today. Polypharmacy often is a symptom of long wait times for care or other factors that may result in multiple medications that conflict with each other or cause damage to the individual, insufficient clinical capacity, fragmented care, and lack of accessible alternatives to medication may lead to over-reliance or mismanagement of pharmaceuticals. And unfortunately, what we've seen is longer waiting times for access to care. Reports indicate that there is a serious deviation from VA's commitment to evidence-based, veteran-centered mental health care. And I have written to Secretary Collins about it. I'm going to put that letter in the record as well. The VA has lost a lot of its staff, which could account for those delays, and it needs to be in the position to have the resource to restore its mental health care network. And let me just say finally, by way of this introductory statement, that Dr. Fletcher, I was concerned that the VA has instituted a co-payment for holistic treatment like yoga, fitness classes, meditation, whole health coaching that allow veterans to rely on treatment other than just medication. And I think that is really counterproductive. So I look forward to our questions, and again, my thanks, Mr. Chairman.
You're welcome, Senator Blumenthal. Let me begin with a broad question to each of you. In part, what precipitated this hearing was the reporting from the Wall Street Journal that highlighted troubling examples of veteran medication experiences. From each of your perspectives, how closely do those cases align with what your office or organization is seeing, and where do they differ? In other words, tell me whether what you see is what is reported in that article and what we should know about that. Start with you, Ms. Hundrup.
Thank you. So in our work, we had found there's a number of factors that influence providers' decisions to prescribe. They ranged from the resources at a medical center to complexity of the conditions, the comfort level with prescribing, as well as the availability and the types of treatment. So there's really a lot that can influence it. At the time, we did find there was, at the time of our work, which was based on fiscal year 2018 data, so it's a little bit dated, there were 37% of veterans with one mental health condition that were prescribed a psychiatric medication, either alone or in combination with therapy. And focusing on even more, those with PTSD taking medications, of those taking medications, where polypharmacy comes in, them taking 2 or more classes ranged from 32% from a primary care provider to upwards of 61%. Now, as has been stated, polypharmacy in and of itself isn't necessarily problematic. So in preparation for this hearing, we were looking to see if there was updated data on where the VA is in terms of just polypharmacy. Again, not to say that that alone is bad. It does increase risks. That was not available, so I would encourage the VA to make those data available, and it is worth examination. What we did recommend is making sure the treatment plans have clear, identifiable information so that they can monitor that and see where there are risks and mitigate those risks, such as if a provider is doing a lot of prescribing and you see a lot happening, you can look into that and see if that is appropriate to make sure that they're mitigating any risks or taking action if that may be the case.
Is that a suggestion so that we could compare what takes place at the VA with other healthcare providers?
Well, just to have a number of, to update where we were, a lot has changed since 2018. So just to understand veterans, for example, with PTSD or other mental health conditions, what kinds of prescribing, what kinds of classes of medications, psychiatric medications are they getting? For a while, there was a lot of concern about opioids in combination with benzodiazepines. I know that had been reduced greatly, and that was something that the VA made great strides in. But where are we today? Has that continued to decrease? I think some of these allegations in the article, we just don't have the data, so we don't know. So I think the first order of business is really seeing
Fresh
updated data.
Okay, thank you. Doctor, anything to add or suggest?
I was actually quite disappointed in the article. I think it is devastating to read about the patient experiences. Those are real. Oh. It is. How about now?
Yes.
Yeah, I found the article disappointing. The cases were devastating. The patient experiences are real. But what I didn't, and I wouldn't expect to have, is what the medical records show, what the provider and healthcare team, what their response would have been and how they supported the patient. These were complicated patients. It's easy to understand that from reading the article. And VA treats very complicated patients. I was also very disappointed that the suggestion is that the VA providers are handing out medications to avoid providing adequate care. That's not what we've seen. We've been in every facility, CBOC, vet center, CLC. This is not what we're seeing. We are seeing compassionate, dedicated providers managing incredibly complicated patients.
Great to hear. Thank you. Ms. Fletcher, Dr. Fletcher.
Yes, thank you for the opportunity. So what we hear from the warriors we serve is that they often encounter medication recommendations before therapy is offered or even accessible. And so we know this doesn't happen everywhere, but we've heard it consistently enough that it suggests an opportunity to increase access to first-line psychotherapies and more shared decision-making in the treatment planning process.
Is what you're saying different than what Dr. Kroviak was saying?
No, I think there's a lot of similarities.
Similarities.
Yeah, a lot of similarities, yes.
Okay. Senator Blumenthal.
Thank you. Dr. Fletcher, to what extent have waiting times for mental health appointments been due to diminished staff? And I'll ask the same question of our other witnesses as well.
Thank you for that question. So what we've heard again from the warriors we serve is that they are experiencing access to care difficulties, and that can create problems. We know that warriors with the best outcomes have access to evidence-based treatment, are well-informed about the medications that they are taking, and again, are active participants in the treatment planning process.
Dr. Kroviak?
Yeah, we are aware of shortages in mental health providers and access to care within mental health in VA. That's not unique to the VA healthcare system. So the wait times we're seeing in VA are also reflected in the wait times that veterans are experiencing when being referred to the community. So it is a much bigger problem than just VA.
It's not unique, but what is maybe unique, certainly unusual to the VA healthcare system is that it is discouraging talented mental health professionals from coming to the VA through policies of furloughs and firings. Would you agree?
So I will say through our cyclical reviews where we go out to facilities not for cause to try to get a feel for culture and quality of care practices, we are getting more feedback that morale is going down because of the uncertainty within the federal government. So yes, while they aren't participating in the DRP or didn't participate in the DRP or other programs, clinical staff were exempted from that they are still losing clinical staff because of morale.
Morale going down means
Correct.
that fewer talented and skilled professionals are going to come to the VA or stay. They're going to be leaving if morale.
Yeah, I mean, I have to say these are discussions we have with leaders. We are not asking them to validate the data, or they're just sharing in a conversation the concerns at the local level.
Did you have anything?
I would
Ms.
just
Hundrup?
quickly echo what Dr. Kroviak said about the nationwide shortages applying to both VA and inside as well as outside. I would just also, in terms of distinguishing between within VA care and outside care, for the VA, there is a timeliness standard for care in a VA facility. They don't have that for receiving care in the community, which means that VA is limited in its understanding of how long it's taking for a veteran to be seen in the community, or what the challenges are, how best to address them. And we do have an outstanding recommendation for VA to establish a timeliness standard, which would help give us more information about the differences. And of course, timeliness of care is an access to care issue, because the longer a veteran has to wait, that can exacerbate health issues. Thank you.
And of course, the Wall Street Journal article the chairman referred to a little while ago, Combat Cocktail, How America Over-Medicates Its Veterans, I think indicates that the care for them, mental health care or other kinds of care, is really important to prevent the over-medication that often results from the cocktail of pharmaceutical drugs that may be prescribed sometimes wrongly or inadvertently. And I wonder if you can say, Dr. Fletcher, whether there should be stronger safeguards, oversight to prevent that kind of problem.
Thank you for that. What we hear from our warriors is that they want to spend more time with their providers. They want to fully, process through their trauma, their symptoms. They want to be informed about the medications that they're being prescribed. We know that consistent follow-up increases chances of treatment adherence and treatment compliance. Consistent follow-up allows providers and veterans to identify medications that may not be working properly, avoid symptoms, side effects that become too uncomfortable. That consistent oversight is important to successful clinical outcomes.
Well, again, my time is about to expire. Let me just say that I appreciated both the OIG and the GAO findings, which I think are tremendously important. Just as one example, 33% of VHA facilities were not in full compliance with requirements to have a pain management team. That seems like a really basic failing. And again, you can't have pain management without the personnel to do it. And I think, unfortunately, the VA is sacrificing that tremendously important capability. Thank you, Mr. Chairman.
Senator Tuberville.
Thank you, Mr. Chairman. Thanks for being here. Good to see y'all. Very important issue. We have a lot of problems in my state of Alabama with overprescribing at times. Dr., you and Ms. Hundrup spoke about enhancing oversight at the VA in medical management related issues, especially a better hold on medical professionals accountable for overprescribing harmful medications. Do we have a plan for that? Both of you, could y'all answer?
So ultimately, the plan is VA's, but what our oversight work has shown that a lot of critical leaders in the VISN, which is a body that exists to oversee the facilities, do not have defined roles and responsibilities and clear lines of authority. So VA has a plethora of directives and policies that are based in evidence. However, it's the consistent application of those policies and practices where we find most of the issues that we report on. With structured oversight roles within the VISN, where leaders know what is their responsibility, it is written down and they own it, and that certain staff and procedures and practices are accountable to that leader, can really help enforce. We feel it could really help enforce the more consistent application of these directives and policies and practices that they have plenty of.
Thank you.
I would also, again, echo Dr. Kroviak. I think we have many similar findings and share the same sentiments, but I would just add that in our work, I think by having VA more clearly document the treatment plans that are in a mental health care plan and have them be easily identifiable, as well as document that what evidence-based treatment options were considered. Obviously, in many, many cases, it's very complex. There's not a straightforward answer. There does have to be adjustments very specific to the individual that change over time, and these are complex cases, so you might have multiple medications involved. But by having that documented and clear in the record, it sets up VA to be in a position to monitor that, and they had committed to reviewing individual providers' plans, a sample of plans on an annual basis, just to make sure. I think, as Dr. Kroviak said, some of the policies are only as good as they're implemented. So, I would be interested to see what VA is doing to continue to monitor and look for outliers, and then take action with providers that may not have the best education or may not be making the best decisions for their veterans.
Do y'all think we should have oversight on foreign manufactured drugs that we give our veterans? Is there any thought on that?
Thank you for that question. I think where Wounded Warrior Project would stand on this is we want our veterans to be as informed as possible about the medications that they're taking. We want treatment recommendations to be evidence-based, research-informed, and prescribed in the safest manner possible.
Yeah, I don't have a specific comment on the oversight. You're being meds manufactured over
foreign manufactured.
Yeah, I mean, I
Which
again,
which most of them are, by the way, anyway, I would think.
right. I mean, this whole medication reconciliation process that I've emphasized in my testimony is really more about the interaction between the prescriber, the provider, and the patient. I think that's where all of this sort of action has to happen, to where everybody's on the same page. It's really outside of the VA to where the question you're asking would be, put into play. And absolutely, I would not, speak against increased scrutiny over the safety of the medications that we're buying and prescribing.
I would just echo that. That's not something that I have familiarity with, but I think that's an important topic that VA should be closely looking at.
Thank you. How much time? I got 45 seconds. Ms. Fletcher, I hosted a field hearing in Montevallo, Alabama this spring, talking about HBOT and psychedelic-assisted therapy. You think that expanded access through FDA approval of these types of therapies could and would help address the polypharmaceutical issue?
Thank you for that question. I think that access and research into alternative treatments is something that a lot of the warriors that we serve would be interested in. We hear oftentimes that they're coming to us saying that that they've tried more traditional therapies and are more eager to pursue the non-traditional therapies when they haven't found that success. But again, we would want these treatment recommendations to, again, be based on patient safety and evidence informed.
Thank you. Thank you, Mr. Chairman.
Senator Hohenau.
Thank you, Mr. Chairman. Thank you very much for the panel. So we have millions of veterans, and a rather large percentage of them have PTSD. And according to the Wall Street Journal article, nearly 60% of VA patients with PTSD, and I don't know what that translates it into numbers, but they say that's over 500,000 patients. Are each of these veterans with PTSD supposed to have an individual treatment plan? I don't know who to ask this question to. Yes? No?
Yes, I think that having an individualized approach to treatment yields better outcomes.
I know that's not my question, though. Do each of these have over 500,000? Let's just focus on the veterans with PTSD. Do they each have a treatment plan? And who's supposed to come up with a treatment plan for each
So
of
if
these
they're
veterans?
diagnosed with PTSD and being treated, then they are required to have a treatment plan that is created and monitored by their healthcare team.
And Dr. Fletcher, you deal directly with the veterans of the two other panel members. So do they have individualized treatment plans?
I would say that varies across veterans and across
sorry,
different.
what?
I would say that varies. I can't speak necessarily for all of the veterans. We typically hear that when they're afforded the opportunity to have the access to this evidence-based treatment, that it can be individualized, but it's not always.
Well, when you think about the number of veterans we have and their medical needs, and they go to VA, it's just astronomical. The needs are astronomical. And at a time when there have been pretty significant cuts to VA, which always had a shortage of providers. Isn't that true? I mean, in Hawaii, they're always trying to hire people for the VA. So there's always been a shortage. It's been exacerbated with this regime. Isn't that so? That shortage. Somebody?
So the OIG publishes a report annually on critical staffing shortages, and for the past 8 to 10 years, I can't remember exactly, but this year, yes, you are correct. We've noticed the most significant increases in those critical staffing
at the same time
shortages.
as I think Dr. Fletcher GAO, I think you said that there needs to be, yes, more oversight. And when you have the staffing cuts, et cetera, who's supposed to provide the oversight that you are recommending? This is for Ms. Hundrup. Am I pronouncing your name
Yes,
correctly?
no, that's correct. Yes, no, that
So you
is,
say more oversight is needed, but there are massive cuts to VA. Who's supposed to provide the oversight
well,
for the medical care of the veterans?
right. I think that that's where there is a level of oversight to ensure, because as I mentioned, if you have a policy or requirement, it's only as good as the
No, but do we,
implementation.
you're saying that they need more oversight, but there isn't more oversight. In fact, I would say there's less because there are cuts. There have been cuts to the VA's capacity to provide care. So what I'm seeing is that I commend you all for pointing out the needs, but how are the needs supposed to be met when the VA is actually making pretty significant cuts to an already strapped healthcare system, the biggest healthcare system in the country? Let me move on to, I don't know how the veterans are supposed to receive the kind of care they need when there are cuts to the provider base. Ms. Fletcher, I was intrigued by your saying that veterans would like to have alternative kinds of care. And is that a fruitful avenue for us to support and pursue if we're not going to have all the mental health providers that are necessary? Non-traditional services? Are we doing something to provide those kinds of
I think
programs?
I think that there is absolute value in pursuing research to support these alternative therapies. What we've typically heard, again, is most of the warriors that we serve are willing to avail themselves to the frontline treatments that are already available. What we hear is they seek these alternative therapies when what they've tried hasn't worked. And we always want, and so a commitment to innovation in mental health care is absolutely needed.
Do you think that that is a fruitful way to go? Because we are lacking, the VA system lacks providers, especially I would say mental health providers, maybe primary care providers. But if we can create an environment where alternative kinds of support can be provided, is that a fruitful way for us to proceed?
Yes, I do
Fletcher?
believe there's value in pursuing alternative therapies.
Well, that may be one of the ways to go when we lack resources. Thank you, Mr. Chairman.
You're welcome. Senator Sheehy.
Thank you all for coming today. Appreciate your commitment to this important cause. As a combat veteran myself, married to a combat veteran, I take a very personal stake in all these matters, and thank you for your commitment to the cause. I think to respond to some of my colleagues' comments there, all the more reason why the community care model was introduced and is more critical now than ever, which is the VA has perpetually been under-resourced, especially in rural states like Montana, where you cannot have a VA clinic in every town. And when most towns are 2 to 3 hours apart, when it's a 5-hour drive from Plentywood to Helena, the expectation that a VA clinic will be available within reasonable driving distance in a negative 30-degree snowstorm is unlikely. And taking advantage of the community care options and investing in community care, especially in our rural states, is just as important now more than ever. You made a great point today, Dr. Fletcher, that I want to reinforce, and that's the alternative care model that we're seeing so many veterans now flying to Mexico, flying to the Middle East, going to Turkey to get psychedelic treatment, that they're finding immediate relief from PTSD, from TBI. They're finding it to be safer, healthier, and far more effective for them and their families. And yet that type of treatment is not only not provided by the VA or our healthcare system at all, it's been stigmatized and in some cases treated as illegal, even though it's working far better. And I think whether it's acupuncture or dry needling or yoga, meditation, sleep therapy, or alternative psychedelics, we need to be open-minded about how we can adopt these therapies. And unfortunately, this isn't a knock on the VA, but the government is not inherently going to be an innovative, entrepreneurial, creative place. It's just not. It's opposed to the DNA of a government bureaucracy, and we shouldn't fight that. We should welcome that and say outside groups like Wounded Warrior Project, like other nonprofit organizations, can be those hotbeds of innovation, and we should be able to welcome those in and welcome their creative thought process. Because at the end of the day, it's about the outcomes, not the process. Veterans not victims, patients not bureaucracy, and outcomes over process. And at the end of the day, that's what we have to focus on. So thanks for your comments there. Ms. Hundrup, I want to go back to a comment you made. I think it was incredibly relevant. I'd like your thoughts on that. You said, no matter what the legislation or the policies are, if they're not executed properly, none of that matters. And I think that's that is government in a nutshell at the end of the day. We can all pass laws, but if the people that we employ to enact those policies aren't the right ones or not doing it properly, it's going to fail. This written informed consent law we're trying to pass, I think, has broad support across the veteran, the nonprofit, and the healthcare industries and communities. I'd like your thought on how, should this pass, how we ensure that when it passes, if it passes, we enact it properly and the outcome is what we want.
Yeah, I think informed consent is important because it's an explicit way to ensure the patient knows about the risks of the medications they may be taking. In the case of the Opioid Safety Initiative, we did find that the informed consent was lacking and recommended that VA take steps in implementing our recommendation. They implemented a tool, so in the medical record, there's a flag to show whether or not, my understanding is to show whether or not that informed consent for long-term opioid therapy was discussed and signed by the patient. So I would suggest perhaps a similar approach where in that medical record, if it is expanded to other psychiatric or other medications for informed consent, there could be a similar flag that in prescribing it, it blips up on the medical record and they can then have that discussion with the patient, including the date that was had.
Do you feel the VA is currently structured to be able to effectively implement this rule? Should we pass it?
I will acknowledge it's been a while since we looked at this, but I do understand that what I understood is that tool was in place in their medical records. Now I will acknowledge a lot is happening with the medical records right now in the transition, but should what we understood to take place when they implemented our recommendation in 2020 still be there, still be utilized, I think it's worth asking. I think my understanding is it could be a simple process to add that and that providers would be continuing to do that. I've not heard any cases where it has been lacking, but again, it's up to each provider in that medical record to document that for that individual veteran.
Now, on its face, unrelated, but all things relate to this. Do you think this is yet another reason why we must re-emphasize electronic health records linking DoD health records that have a seamless pass-through to VA health records so we do not have to continue to waste billions of dollars and years and lives losing medical records from years in service from combat injuries that have been meticulously documented by the DoD, and then we throw them in the trash and rebuild them from scratch for the VA, which takes years, missing treatments, missing symptoms, and failing our veterans. Is it finally time for us to have a DoD to the VA health record that is seamless and there's no delay and there's no ledge that people fall off of?
Absolutely.
Thank you.
Senator Sheehy, you might want to tell our colleagues about the plan for a roundtable that you've asked me to conduct, to have a conversation about a topic that you described in some of your questioning. So next Tuesday at 2 o'clock, you might tell us what you have in mind.
Thank you, Chairman. Yes, we're going to talk about our alternative treatment ecosystem. After I was wounded, I was privileged to undergo some processes at Walter Reed, which were eye-opening for me. A lot of the alternative treatments that we've talked about, psychedelics, sleep therapy, yoga, et cetera, but specifically the availability of psychedelics and how we can bring those into the VA system, into the broader veteran healthcare ecosystem, as we're seeing really a tremendous caseload of feedback from veterans and patients who've benefited from that treatment very specifically and come back and testify that these treatments are having an incredible impact on them. And the side effects, at least so far, are minimal to negligible. So thank you for giving me an opportunity to bring that up. It's going to be hopefully a pretty insightful session. Thank you.
You're welcome. Thank you for your leadership and interest in this topic. In committee, we have not invited every committee member, but you're all invited. We invited everybody who's on this committee that has been engaged in this psychedelic treatment aspect of pursuing policy. And but if anybody and all are welcome to come, and it's next Tuesday at 2 o'clock. Now, Senator King.
Thank you, Mr. Chairman. I want to emphasize what Senator Sheehy just said. As I looked over my notes and my questions, it all comes back to decent electronic medical records. You talked about coordination with community care. Good electronic medical records. Coordination with veterans coming out of the Defense Department. Decent electronic medical records. It just, everything comes back to that. I mean, the over-prescribing or prescribing polypharmacy where there's conflicts and danger, that's where you get, that won't happen if you have decent medical records. So every practitioner that sees a veteran sees the same information about what they're taking, what they've been prescribed, what their history is, all that necessary background. So the development of electronic medical records for the Department of Defense and the VA has been an absolute debacle. And we're spending billions of dollars. It's still not working. It's been tested. People don't like it. I've never understood, frankly, why we didn't use the same system that's already on the shelf for thousands of hospitals across the country. Why are we inventing a whole new system for these patients? But sorry about the speech, but Senator Sheehy provoked it because he's absolutely right. A personal story. Just recently, I talked to an elderly friend, and in our conversation, I realized that she was much sharper and more engaged and with it than had been the case just a month or two before. And I didn't really think too much about it until I later talked to her husband, who said she had a fall, she had a broken knee, she went into the hospital, her physicians looked at her prescription record and changed the prescriptions, and she's a different person. Nothing else happened other than taking her off certain drugs, putting her on others, and adjusting the volume, if you will. And so this was totally obvious, and all it was somebody seeing cohesively what the prescription record was, and I'm sure that's happening with thousands of veterans. One question I have is, this seems to me a prime area where AI could help. AI could tell you whether there are contradictions and problems. I mean, I think that's one area. Everybody's talking about AI and all the problems, but this is something where AI could quickly and instantly analyze. It would have every drug in the world, and you put in what would happen if this person is taking these 3 drugs and I prescribe this. It would give you an instant answer. Isn't that true? You're nodding. Nodding doesn't show up in the record. You have to say, yes, Senator, that was a brilliant comment.
Yes, Senator. That is not a topic we've looked at in depth, but I do think you're absolutely right. And in terms of just even some of the record sharing, we do understand from VA in terms of them stating their intent to implement our recommendations that they do anticipate using medical technologies like AI. So I think just to loop back to the need for oversight and the need for more people, I do think there is promise that AI could alleviate some of that. We're very, very early, and that's not something that GAO has looked at specifically, but so I need to stop there, but I think it has a lot of promise.
One of my questions is there any part of the VA routine that involves an annual checkup of your medications? Is that something the VA does routinely? It seems to me that would be a useful tool.
I can take that question. So within an EHR, including the old CPRS that VA uses and the new Cerner record, when you prescribe a new medication, the software itself is taking that one medication against the list of medications a patient is already prescribed or against a known list of allergies the patient has reported. So what you're saying is happening in even the most basic EHR function. The issue is an alert can pop up that describes the risk level of that interaction. So the provider in that moment has to make a determination like, yes, I know this risk exists, but I'm taking the risk because it's worth whatever outcome or treatment plan I've established. So what you're saying is happening. It doesn't require new technology.
There are regular reviews of medication?
Every time you see a patient, this medication reconciliation process should be happening between provider and patient. But the software that they're using when you enter a new medication will run it against the inventory of what's already being prescribed to make sure those interactions aren't happening that you're worried about.
And one of the things you mentioned was a possible lack of communication and coordination with community care.
Yes.
That's correct? So that's a gap we should be paying attention to.
It's a massive gap that we've reported on frequently. There is a technological solution one day when all EHRs communicate with each other. That's the ultimate solution. We are nowhere near that.
And there's no excuse for being nowhere near that in this day and age. but I deeply appreciate your testimony. And I hope you'll follow up as a result of our questions and what the committee is after. Let us know what we can do to help. That's our job here. And you can be our eyes and ears in the field and say, here's a gap, here's a problem, here's where either oversight by this committee or legislation by this committee could help to fill those kinds of gaps. Thank you very much for your testimony. Thank you, Mr. Chairman.
Senator Hassan.
Well, thanks, Mr. Chairman and Ranking Member Blumenthal. And to our witnesses, thank you for your support of veterans. Ms. Hundrup, I wanted to start with you. As you highlighted in your testimony, veterans often experience hardships in the transition period where they leave the military and re-enter civilian life. As you know, the GAO recommended that the DoD and VA's Joint Executive Committee, which oversees the coordination of health care and benefits between the military and the VA, assess the effectiveness of DoD's and VA's efforts to facilitate access to mental health services for these transitioning service members. So can you discuss why it's important to make these kinds of assessments and how they can help lead to potentially improving the health care that our veterans are receiving during this critical time?
Yes, thank you. So in our work, we identified a number of helpful touch points across the transition continuum, which is 1 year before separation to 1 year after. However, there was oftentimes some confusion about which program they need to or how it works, sometimes an awareness, lack of awareness. Some of the programs we found were late. So for example, there were 2 programs, Solid Start and In Transition, both noble programs with good intent, but they were identifying the veterans 2 to 3 months after separation, which is already very late in the process. And so, and there was also potential duplication, getting similar phone calls, which was just resulting in confusion on the part of the veteran maybe being overwhelmed, not knowing. So not only was it late in the process, but looking across, there are a lot of different programs. I think each individually have, again, noble goals and provide critical services. But looking across, there was, maybe some in some places that were a little too late, some that might be.
Right. But can you, as we look at assessing this, especially for mental health care, what is the value of this assessment in terms of mental health access?
So the value of this assessment will be to look across and identify the timing, whether there are gaps, whether certain things could be done earlier, whether, for instance, is the separation health assessment is supposed to have a mental health assessment. That's not happening now. Okay. So I think they could identify what is happening, where there are gaps, maybe there's overlap or duplication, and really look systematically across, which I think could result in some savings on the part of DoD or VA or both, and they can take those and shift those so that's really coming at the right time in a clear manner for the veteran that is better understandable. So I think it's going to result in a more cohesive, holistic approach.
And I think that's, critically important as somebody who advocated it and worked on the Solid Start program. The idea was day one of the transition, there would be these things in place, right? And that means that the organizations have to start planning before the veteran separates. Dr. Kroviak, let me kind of follow up in a way on what Senator King was just talking about, because one of the issues you've raised is medication management for veterans who are receiving community care. And you've discussed it's really important that veterans who receive community care have their opioid prescriptions coordinated and monitored by the VA. The coordination and oversight obviously can be life-saving for veterans struggling with pain and mental health conditions. In 2023, the Inspector General's office looked into VA oversight of community care opioid prescriptions and found, and this is a quote, gaps in care coordination, documentation, and the use of risk mitigation strategies for system patients receiving community care. In your testimony, you stated that 2 of the 7 recommendations from that 2023 report still haven't been implemented. So what problems remain in terms of ensuring that community care providers and the VA are working together to ensure that veterans, especially those who are being prescribed opioids, are getting the safest, best care that they can, and what can we do in Congress to help?
Yeah, so I think those 2 recommendations you're referencing are specific to that information sharing, and we have been working with IVC, which is the Integrated Veterans Care Program Office that runs community care. It is a struggle to ensure that communication and oversight of that effective sharing of information, and it will require likely changes to the contract, modifications to the contract that VA has with the TPAs currently. They are up to renew that contract in the coming year. They are taking our considerations and concerns very seriously, and we meet with them quarterly to discuss how we can move forward with ensuring these things happen.
Well, let us know if we can be helpful in that way in urging
thank you.
forward. I'm just about out of time, so I'll follow up in writing, but I am continue to be really concerned about the issue of veterans, especially with mental health issues, being given the right kind of follow-up instructions about their medications when they're discharged. So I'll follow up with a question in writing for you on that. Thanks, Mr. Chair.
Senator Hassan, thank you. We have another panel, and we have not yet called the 4:30 vote, so we might be in good shape for the hearing to conclude. I'll quit talking to improve the chances, except I don't have time to ask these questions, but I'm very interested, Dr. Kroviak, in community care, and it seems like other members of this committee are. I don't know whether the problem, I suppose because we don't have the information, the coordination, we don't know whether there has been real-life problems for the veterans or whether it's lack of ability to demonstrate whether that exists or not. So I'll follow up with my staff and you to have that conversation, like are veterans at real risk or we don't know? And it's not just a paperwork issue. I don't mean just, because records important, information matters. And I'm interested, of course, in the Eastern Kansas report that you alluded to and want to hear more about that. And then I think it was you, Dr. Fletcher, that maybe said something about prescription first image. I want to know whether the prescription first image has a basis in fact, or whether it's just something that is said. And then also there is an impression that the VA has been successful in overprescribing opioids, and I'd like to know the facts about that belief. Darn. And so those are the things I want to follow up, and I'll ask my staff and you to have those conversations. I thank you. Oh, I knew if I did this that Senator Blumenthal would think he was entitled as well.
Just a really quick question, which I neglected to ask before, Ms. Hundrup. The Wall Street Journal article says, and I'm quoting, only 15% of veterans diagnosed with depression, PTSD, or anxiety are offered psychotherapy in lieu of medication, according to a 2019 report by the Government Accountability Office. Is that percentage still accurate?
Unfortunately, I don't have updated data on where we are with that, which is, to my earlier point, is I think it's worth following up with VA since publicly available data on that is not out there.
If you could follow up, I would appreciate it. But you know of no reason that number has changed.
I don't know that that would necessarily change, no.
Thank you. Thanks, Mr.
Senator Blumenthal, thank you. Thank you all very much for your testimony. Appreciate your commitment to this cause. And with that, you are dismissed quickly. And I welcome our second panel quickly. Testifying today on the second panel is Dr. Ilse Wiechers, Deputy Director, Office of Mental Health, U.S. Department of Veterans Affairs, and she is accompanied by by Tom Emmendorfer, Executive Director, Pharmacy Benefits Management, U.S. Department of Veterans Affairs. Thank you both very much for your presence, and Dr. Wiechers, you are recognized for your testimony.
Good afternoon, Chairman Moran, Ranking Member Blumenthal, and members of the committee. I am Dr. Ilse Wiechers, Acting Deputy Assistant Undersecretary for Health for Patient Care Services at the Veterans Health Administration. I am joined today by Dr. Tom Emmendorfer, Executive Director of Pharmacy Benefits Management Services. Thank you for the opportunity to speak with you about how VA ensures safe, effective, and veteran-centered medication management, and to share our views on the 3 bills under consideration today. As a practicing VA psychiatrist for over 15 years now, I am aware of the complexity of medication management for our nation's veterans. Many veterans live with multiple chronic conditions like PTSD, chronic pain, and substance use disorders, which often require complex treatment plans. While multiple medications may be necessary, we recognize the risks of polypharmacy and are committed to reducing unnecessary or unsafe prescribing. VA has built a strong foundation for safe medication use through our national formulary and evidence-based prescribing practices. We use real-world data, not market incentives, to guide decisions. One example is our use of pharmacogenomics, which helps tailor medications to a veteran's genetic profile. This approach is improving outcomes and reducing adverse drug events. We have also made significant progress in opioid safety. Since launching our opioid safety initiative in 2013, we have reduced opioid prescribing by 68% and cut concurrent opioid and benzodiazepine prescribing by 90%. Tools like the STORM dashboard help us identify veterans at high risk and coordinate care to prevent overdoses. VA has continued to make it easier for veterans to obtain the life-saving medication naloxone. We distribute naloxone widely, over 1.8 million prescriptions to date, as well as providing overdose education to veterans and the caregivers. Naloxone is available free of charge to enrolled veterans in various forms. It can be accessed through VA pharmacies, mobile units, community events, and even by messaging care teams through the VA app or website. In addition, we are continuing to advance the Psychotropic Drug Safety Initiative, or PDSI, a decade-long quality improvement effort focused on safer prescribing of medications for mental health conditions. PDSI has helped reduce inappropriate use of benzodiazepines and antipsychotics, especially among veterans with PTSD and substance use disorder. Despite these successful initiatives, we acknowledge there is more work to be done. That's why VA recently issued a request for information to identify innovative software solutions that can support individualized medication review and deprescribing. This is part of our broader effort to address polypharmacy and ensure that every medication has a clear evidence-based purpose. Now, I will turn briefly to the legislation before the committee, noting that our full views are detailed in my written statement. VA supports the End Veterans Overdose Act, subject to amendments. We agree with the goal of expanding access to naloxone, but we are concerned about removing prescription requirements entirely. Prescriptions help ensure accountability and stewardship of government resources. That said, we've already taken steps to make naloxone widely accessible, including permitting the use of standing orders or prescriptions for any veterans at risk of overdose. We remain committed to increasing the availability of overdose reversal medications like naloxone to save lives. VA supports the Protecting Veteran Access to Telemedicine Services Act, also with amendments. VA greatly appreciates the committee's engagement and attention on this issue, as well as the willingness to discuss technical issues VA has identified with the bill. VA recommends amendments to ensure this new authority effectively addresses the two significant barriers VA has experienced in ensuring providers can furnish care, including prescribing controlled substances, to veterans through telehealth, restrictions with the CSA and within the CSA, and variability in state law prescribing requirements. A clear federal framework would help us deliver consistent care to veterans wherever they live. VA has concerns with the Written Informed Consent Act. While we support the goal of informed decision-making, requiring signature consent for a broad range of medications could lead to unintended consequences, such as a delay in access to care and increased stigma to mental health treatment that might deter veterans from accepting needed care. Our current policies already require completion of informed consent discussions and documentation in the electronic health record that is tailored to clinical risk. In closing, VA is committed to ensuring safe, effective, and veteran-centered medication management that helps improve the lives of our nation's heroes. We're proud of the progress we've made, but we know there's more to do. We'll continue to refine our practices, expand access to innovative treatments, and put veterans first in everything we do. Thank you for your time and your continued support. We look forward to your questions.
We need to ask questions in light of
Mr.
our
Chairman,
schedule or
I
a
have
vote.
to leave unfortunately for another meeting, but I want to compliment the department for the dramatic reduction of opioid prescribing. I think that's
I'm happy to
important.
yield to you, Senator King,
No,
if you
that-
want to ask.
No, that's all I wanted to comment on. Thank you very much.
Thank you. Let me ask, Dr. Wiechers, I noticed that you are on the faculty at Yale, so you're familiar with our VA facility in Connecticut, and as you know, Secretary Collins has repeatedly stated that access to VA care has not been affected by staffing reductions, but the VA's own data, in my view, tells a different story. Wait times for new mental health appointments have increased sharply since January in my home state, Connecticut. For example, the most recent data shows the current wait time for a new patient mental health appointment at the Orange VA clinic in Connecticut, an outpatient facility specializing in mental health, is 208 days, nearly 6 months. Let me ask you, given these kinds of wait times, how does the VA plan to prevent over-reliance on medication when veterans can't access these timely appointments? And what steps are necessary to address this issue?
Thank you for the question, Senator. I agree that access to timely mental health care is one of our top priorities. We continue to actively be recruiting and hiring mental health providers across the system. We are working to address the access challenges that you have noted, and it does vary from facility to facility. So acknowledge that there are differences based on location, but we're doing work now to identify areas of ways we can improve our efficiencies so that our workflow and our ability to see patients and get them
You don't
access quickly.
dispute the data showing those wait times?
I acknowledge that there are wait times at some facilities that are beyond what our expectation and standards
I've
would
also
be.
heard credible reports that some VA psychologists are being instructed to cap the number of sessions they can offer patients, even when, in their professional judgments, additional sessions are clinically necessary. I don't know how you justify that kind of practice.
There is no cap on the number of psychotherapy appointments that a veteran can have. There's no national policy.
So
and that wouldn't be.
you dispute that there are any caps that psychologists have been instructed to impose?
We support the implementation of evidence-based psychotherapies. Many of those evidence-based psychotherapies are a course of treatment that occurs sometimes 8 to 12 treatments, sometimes 12 to 20 treatments. The individual provider working with that veteran is the one who's determining that course of treatment and when it's appropriate to complete that work. But there is no cap set. There is no policy indicating a cap in the number of treatments available. It is a
So
decision
the
made.
answer to my question is yes, you dispute that any instructions have been provided that there should be a cap imposed by
There is no
psychologists.
national policy instructing to have a
Well,
cap in
are
psychotherapy.
psychologists ever told they have to impose caps?
I can't speak to what every individual psychotherapist across the country has been told by someone, but I can say that we don't have a policy that states that,
Well,
and that I wouldn't support
I will
it.
just tell you, I'm going to cut through the verbiage in the interest of time. We've been told by multiple sources that caps have been imposed on psychologists. So if you're not hearing it, I think the VA leadership needs to do a better job of listening to the psychologists and others who are actually providing care. In the interest of time, I'm going to yield.
Thank you, Senator Blumenthal. I'd suggest, Dr. Wiechers, that that you take Senator Blumenthal's commentary to heart and actually explore within the VA whether there's a policy or a written national policy, whether there's a practice that is limiting the ability for the treatment that the provider believes is necessary in some fashion. That makes sense to you?
That does make sense to me, and Senator Blumenthal, I'd like to continue the conversation with you and your staff further so I can make sure I understand what you're hearing better.
I would welcome that opportunity, and I just want to say this is not personal to you. I recognize you're not in charge of the VA healthcare system, and both of you have long histories of service in the VA, which I appreciate. I thank you for your service, and I know you have ultimately the goal of serving our veterans, and I want to be helpful to you in serving that goal.
Thank you, sir.
Dr. Emmendorfer, let me ask you maybe a question. I was able to attend the launch of the Phaser pilot program in 2019. I think it was at the National Press Club with Secretary Wilkie, and which introduced the idea of using a patient's DNA to prevent medication side effects and reduce the use of ineffective medications. I understand that program is successful. I'd like to have that confirmed, and is now available in nearly every VA medical center. How's the VA training providers to use this? How's the VA integrating the results into the VA's electronic health records? Tell me about this program and whether it matters.
Thank you, Senator, and I am happy to report that it is a success. As a matter of fact, earlier this week, we just learned that one more VA medical facility has implemented the pharmacogenomics program, and we expect the remaining 7 VA medical facilities to implement pharmacogenomic testing by the end of the calendar year 2026. For the training, we have over 1,000 VA providers that have participated into the continuing education program on pharmacogenomics. And then we also have our academic detailing services program, which is specially trained pharmacists that have conducted outreach with, I believe, around 7,000 providers to help promote pharmacogenomics. It's well integrated into our electronic health record, so it's part of the clinical decision support system. There's about 100 medications that are evidence-based with the pharmacogenomic testing. And so at the time of prescribing, the computer system, our electronic health record, will flag an alert on the pharmacogenomic testing, and that helps guide appropriate medication selection and therapy. So we're very proud of the program.
Tell me, as the layman on so many things, what does the DNA tell us? What does it indicate? What is it capable of indicating to avoid in the treatment of a patient?
Yeah, so it's helpful with the DNA because it'll tell us as healthcare providers how we would expect that medication to behave when it's in your system and being metabolized by your body. And that information really helps us make that upfront selection of the medication. So in the past, where you may have to do some trials, and then if the patient's trial on the medication wasn't optimal, and then you may have to taper and stop that medication and then try another medication. Pharmacogenomics takes that guesswork out up front.
Thank you. Senator Blumenthal, anything you want to cover before
I would like to submit some additional questions for the record, but
you also indicated you had something to submit for the record, I think.
I'm going to submit my statement and the letter that I wrote to Secretary Collins.
Without objection. I'm sorry to cut this hearing short. Senator Blumenthal and I probably have access to more conversations with you, and I see you nodding your heads, and then we'll follow up with our staff or to make sure that anything that we may have missed because of the vote is covered. With no other questions, I want to once again thank you for your testimony. I thank our committee members for their participation and for our audience. Each member has 5 legislative days in which to submit statements or questions for the record. Any senator who would like to submit a question for the record to today's witnesses should do so in a timely manner. And likewise, I ask our witnesses to respond to any questions that they receive from this effort following today's hearing in a timely manner as well. And with that, our committee hearing is adjourned.